You can't control your day, but yet the corporation and the corporates above want you to try to lasso that experience as much as they can into these finite and arbitrary timings, which really disadvantage not only yourself, but disadvantage your patients. That's the most important thing. They're setting you up for failure, but they're also setting those patients up for failure. To a corporate entity, each and every patient is not seen as an individual patient, it's seen as a dollar sign. And they don't want those dollar signs to walk out the emergency room waiting area.
Paging Dr. Cook. Paging Dr. Cook. Dr. Cook, you're wanted in the OR. Dr. Cook, you're wanted in the OR.
Welcome to the Prescription for Success podcast with your host, Dr. Randy Cook.
Hello, everyone, and welcome to Prescription for Success. I'm Dr. Randy Cook, your host for the podcast. As a reminder, Prescription for Success is a production of MD Coaches, a company providing leadership and executive coaching for physicians by physicians. To overcome burnout, transition your career, develop as a leader, or whatever your goal might be, visit MD Coaches on the web at mymdcoaches.com, because you're not in this alone. Well, my guest today is a residency-trained, board-certified emergency physician who has developed a rather intense interest in the corporatization of medical practice, especially as it applies to emergency medicine. She's been very outspoken on the subject, and I think you'll be very interested in what she has to say. So let's listen to my conversation with Dr. Saba Rizvi. And I am delighted today to be having a conversation with Dr. Saba Rizvi, located somewhere out in Texas. First of all, thank you so much for being here, Saba. It's great to have you. And where exactly in Texas are you?
Oh, thank you for having me. Currently, I'm in Waco, but I also reside in Austin, Texas.
Well, I know that you do a lot of getting around, and we're going to talk about that a lot during the show. So if we could, I want to get down to talking about your beginnings, and I'm really excited to talk about this because you actually have a history in the same territory where I am right now, and that is in the state of Alabama. Did your undergraduate work at UAB, is that right?
Yes, I did actually. Did my undergraduate at UAB. I majored in philosophy and biology, so it was a wonderful time.
Are you an Alabama native?
So my father worked in the nuclear engineering industry. He's a mechanical engineer, and we moved around a lot. And he at one point was working for the Tennessee Valley Authority, and then for some energies companies in the Southeast. And that's how we ended up in Alabama.
That's an interesting pair of majors that you have there, and I'm really interested to know if at that point when you were in undergraduate school, did you know that you were headed for a career in medicine, or was it something that was under development? And I got to point out, you not only had a double major, you actually had 2 degrees. You had a BS and a BA, right?
Yes, actually, I do have dual degrees. Yes, a bachelor's in art and a bachelor's in science. To answer your first question, no, I didn't know that I was going to end up in medicine. I, had a passion for the humanities. I always loved to read and thought I might actually, head towards law school, actually, because my grandfather was a judge in India and had some family who had become lawyers here in the United States. And so that seemed to be the natural course that I wanted to kind of follow in. But I also love the sciences, and it's really the intersection of the humanities and the sciences that I really enjoy. But my path took me towards medical school right out of college. And this is where I am. And now I'm going back to pursue my JD mid-career.
That's very interesting.
Yeah.
So what do you think it was? What do you think tipped you toward the healthcare path?
It was a good deal of influence from my dad, actually, who felt that it would just be easier, the objectivity of the sciences, so much easier to navigate, than with a legal degree. He thought maybe there would be some subjectivity influencing my ability to gain equal footing in that realm, being a female, being having an immigrant background. So he wanted me to kind of stick to something that would, as all parents do, they want you to pursue things that are going to make you happy, but also aren't going to be difficult for you. And
Sure.
that's what his advice to me was, that, I think you'd make a great, fantastic physician. You'd make a great lawyer too, but how high can you climb in that realm? So
Yeah. Well, I think that was pretty good advice. And as you say, you appear to be well on your way to accomplishing both. After your undergraduate education, you moved down to Mobile to the University of South Alabama.
yes.
That's where you got your MD. And what was that experience like for someone who had been leaning toward the humanities? What was your first impression and later impressions of medical school? Did you feel like you were in the right place, I guess, is what I'm trying to ask.
Yeah, no, absolutely. I think that we are ordained and destined to be where we need to be at any given point, and I certainly felt that way. I could have gone to a bigger medical school with a 165 class size, but I ended up at a smaller school with just around 60 or so students in my
Yeah.
class, and it was a much better experience, I believe, in the long term, because there was just so much hands-on training with our professors and with the faculty at the hospitals, that I think I got, in the end, a better education. I gained more experience than some of my cohorts.
Yeah.
So I really loved being in Mobile, being near the Gulf, and the culture of the area. So it was fascinating and a great experience.
I'm sure it was a much more personalized experience because I remember that everybody in Mobile was really excited about having a medical school there. And in those early days when it was very small, I bet you got exactly that. Lots of personal attention.
Very much so. For lots of personal attention, and you felt like you could go up to your professors and ask them anything, and the faculty were just phenomenal.
That's great. So then another interesting turn, at least for me, as I look at your resume, for someone with an interest in the humanities like you were describing, I would have bet, now this person is destined to be a family practitioner.
Right.
And yet you chose emergency medicine and you went right back to Birmingham in the heart of the beast. So tell me about that.
I just fell in love with emergency medicine because, for lots of
Instant
reasons.
gratification, right?
Instant gratification. Yeah, that was one of the big reasons. But I loved being a diagnostician. I love being a diagnostician, I should say. I like the purity, the untampered with patient, if you will.
Yeah.
The person that comes in their true form with their disease process, and you have to put the puzzle pieces together to figure out what's going on with them. And that part of it really appealed to me. By the time, in medicine, as you know, that by the time the emergency room is done working up a patient, we've, profoundly changed their course of treatment, and or their diagnosis has already been established or well on the way to being established. So, but the unencumbered patient or the undifferentiated patient that comes in is truly fascinating, because sometimes they mimic what you read in the textbooks, and at other times they're profoundly different. So I enjoyed that aspect of emergency medicine.
Yeah, it's really exciting. And if you will, I'm actually going to backtrack just a little bit, Saba. I know that before you actually apparently made the decision to make emergency medicine your career, you actually did an internship in internal medicine out in California
Yeah.
at a hospital that it kind of fell on some hard times, to say the least. And if you don't mind talking about it, I'd really like to know what your experience was
Sure.
like at
No.
the Martin Luther King
Junior
Drew Medical
hospital.
Center. Yeah.
Yeah. I think we are, as individuals, as people, we are an amalgamation of all our different experiences, and this is what really makes us who we are. And my path took me to California because I did do a year of internal medicine out in LA. Truth be told, there were various personal reasons. I was seeing somebody out there, and that's why I decided to go and spend a year. And also
Sure.
because it was an avenue out of being in a smaller town in the Southeast. I thought I needed 1 year at least in a bigger city to see how that feels while I'm still young. So King Drew Medical Center had fallen on hard times, obviously was under a lot of scrutiny from the Joint Commission at the time that I was an intern there. And, there's a lot of controversy about why that was. And I don't think I'm privileged to talk much about that because it was prior to me becoming an intern there. I can tell you that what I saw was people who really cared about that community and really cared about delivering medicine to the underprivileged and underserved in Southeast LA. And they put all their heart and soul into doing the best they could for the patient population there. So I had a very good experience. I mean, I saw some pathology that, you could not imagine seeing probably anywhere else except for that part of the country. There were patients that would just cross the border from Mexico and from Baja and come in with just either florid sepsis or, just horrible necrotizing fasciitis or, gangrenous in legs or extremities. Obviously, there was a lot of gang violence during those years. It had died down a little bit since I had become an intern, but we saw tons of gunshot wounds, stab wounds. So from an emergency standpoint, when I used to rotate in their ER, it was a fantastic experience to see all this pathology and to see all these things that I don't think I would ever see at any other medical center. Flip side was that they were under heavy scrutiny, and there were certain, members of the house staff there that probably weren't doing the right thing financially for that hospital. And unfortunately, it was a loss for that community. I think it shut down and then reopened as an ambulatory clinic or something of that nature.
My understanding of the story is that they simply closed it and they did a complete rebuild. And if for our listeners who care to look it up, I think it is really an inspiring story of rebirth. I've never set foot in the place, but I can imagine it must have been a terribly traumatic time. And for you, being there not only in the capacity of a physician, but for someone who is there to learn, I can imagine it must have had its difficult moments.
Yes, yeah, it was quite difficult to, we would, when a hospital is kind of teetering on the edge of closure, everything gets scrutinized with a magnifying glass, including the intern's notes and everything that's documented. And when the Joint Commission is coming in and doing almost weekly to monthly checks, you best be on your best behavior. And so we learned very quickly the correct way to document and the correct way to enter things, and everything was done to the T while we were under the gun for that. But it was a different experience, and I didn't get into the politics of the policy as an intern as much, but it was fascinating to see how that was all unfolding. Also, the hospital at the time had hired a consulting firm for multiple millions of dollars to help navigate this process that they were undergoing with the Joint Commission. And, I always wonder about that because they spent so much money on this external firm and ended up still shutting down.
Isn't that interesting?
Yeah.
Fascinating to me how many times it turns out that way. Well, from that experience, as we said, you came back to Birmingham and spent a few years in your emergency medicine residency in Birmingham, and then it looks like you traveled around in Alabama a little bit. You've been to some places that you and I know about, but very few people do. Sylacauga, Alabama, I suspect, is unheard of for most folks.
Yeah.
So, what was your plan at that point after you finished your residency?
I wanted to be near my family again. And so I went back to finish out doing an emergency medicine residency. UAB's residency program was fairly new still at that time, and that it only articulated maybe 3 or 4 classes before us, or maybe even 2 or 3. So it was, again, I always end up with these programs with a smaller class size, which is always so welcome and refreshing, because you
Pretty
get
cool.
so much, you get all this great one-on-one time with your professors and your attendings, and you get this great learning experience. And so that was wonderful. When you're working in emergency medicine, when you have all the bells and whistles of a large academic center behind you, you don't really get to push your skill set or really test your abilities out, if you will.
Remember medical school? You were confident, studious, hardworking, and you learned what to expect in all manner of patient care. Then reality struck. Regulations, expenses, staff management, and administration. Is this what we signed up for? Stress on the verge of burnout, no time for family, or the reason we got into medicine. Helping people. What are the options when you're afraid you're in the wrong career? Transition, teach, quit? What if there was another way? MD Coaches can help. We're a team of medical professionals with a century of experience in the clinical and business sides of medicine. More importantly, MD Coaches has been where you are, stressed and trying to navigate a world school didn't prepare us for. MD Coaches is your mentor, your confidant, to help you make your practice shine, navigate administrations, and successfully lead staff and projects. Or if you're ready to transition, we can help there too. MD Coaches is doctors helping doctors. Visit our website to receive a free, no-obligation consultation. Go to mymdcoaches.com/RX. That's mymdcoaches.com/RX. Isn't it time someone else was on your side? Don't let the business of being a doctor stop you from doing what you love. That site again, mymdcoaches.com/RX. Visit us today.
We'll get back to our interview in just a moment, but right now I want to tell you a little bit about Physician Outlook. If you haven't discovered this remarkable magazine, please do so very soon. It was created by physicians for physicians to showcase the intersection between clinical and non-clinical interests, whether it's writing, painting, cooking, politics, and dozens of other topics. Physician Outlook gives a physician perspective. It's available online and in print. It's really unique among physician lifestyle magazines. And like the Prescription for Success podcast, Physician Outlook amplifies the voice of any physician who has something to say. It also engages patients who still believe in physician-led, team-based care. And Prescription for Success listeners can get 3 months free when you enter our promo code RX for Success and select the monthly option at checkout. That's a really great deal on this stunning publication. And now let's get back to today's interview. Back to your professional life. At some point, it appears that you really developed a fairly intense interest in healthcare economics. And I think I'll just let you tell us where that came from and where it's going.
Yeah, so it's interesting, like I mentioned, really your experiences in life make you who you are. And I've had the good fortune of having a variety, as you can tell through this brief history of mine.
Indeed, you have.
Of working in the smallest of hospitals, in the most rural of areas, and seeing those communities and their healthcare needs, to shifting to mid-sized cities and level 2 trauma centers, and then seeing what that entails as far as medical practice. And I encourage anybody who's a young physician to go out there and try to get a variety of experiences, whether you do it willingly or just that's where life leads you. Don't always shut the door on these experiences, because they really do give you such a global view of what healthcare is like. And so I got to see, not only through my lens, but through what my husband was doing in his practice, the shifts in healthcare were just so palpable for us. We got married in 2008, and by the time I'd moved out, graduated residency was already 2009. And of course, the Affordable Care Act passed in 2010. So I had the experience of knowing what it was like to be a resident and to be practicing as a physician prior to the Affordable Care Act passing. And then, like many other physicians before me, had a tangible, could tangibly feel what was different with healthcare after that, after the passing of the ACA. So, and the experiences that our small town physician friends were having, I really became interested in healthcare economics because I could see this shift and this chasm evolving before my own eyes. And I was trying to figure out why it was happening, didn't understand it. And I wanted to read and learn and see what was going on. So first thing first, as when I was in Colorado, I was working for what we call a democratic group, which is a group of ER physicians, whether that be, our group was fairly large. It had about 15, 16, I believe, ER docs and some mid-level providers who decided to start a practice, and everybody was basically an equal partner in that practice. If you joined as a junior partner, you were given 18 months of an employment contract before you would be eligible to be partner. And for all intents and purposes, it was a very transparent, a very collegial atmosphere. We all took care of one another. We all felt a responsibility to our patients, a responsibility to the organization, a responsibility to our community at large. And it really made for great healthcare. I went from that experience to when I first moved to Austin, entering into a completely different healthcare market. And I hadn't realized that the shifts in healthcare were happening while I was practicing in my mid-sized town or small town. And things were just moving at such a rapid rate towards corporatization of our profession, basically. By the time I got to Austin in 2016, there were no democratic groups that I could join. What I mean by that there were no physician-owned groups that I could join. These were all large conglomerate staffing companies, or what we call contract management groups.
Right.
And with these contract management groups, you didn't have any choice of ownership or anything of the sort. You were going to be an employee or you were going to be an independent contractor, and those were their two options. So I joined Team Health in Austin and promptly was sent to a level 1 trauma center because I had the trauma experience in Colorado, and they thought that would so well serve that facility. What I didn't know was how egregiously bad the staffing was going to be for a place that had very similar volumes to the hospital that I'd been working out in Colorado, which had a huge area that it covered. The smaller hospital in Austin saw an equal amount of patients, but with, I would say, half the staff.
And when you say staff, are you talking about physicians or mid-levels or nursing or all of those things?
Pretty much all of those things. The economics of this started to come into view for me when I started to notice that, where I had been working before was at a nonprofit facility, owned and operated by the Sisters of Leavenworth. And where I ended up was a for-profit facility, the Healthcare Corporation of America, or HCA, the largest hospital corporation in the United States and beyond. So, and for-profit. So I noticed a difference in the way the logistics worked out in that emergency department. I noticed a profound difference in the way it was staffed with physicians who were very skim-on-scat staffing. For example, in our facility back in Colorado, with the amount of patients that we would see, we would have dual coverage during night shifts because it was just impossible for one physician to go about it by themselves. And this was not the case when I came to this facility in Austin, where the coverage would drop down at night to just one physician and no mid-level staffing. In Colorado, we would have at least one mid-level or nurse practitioner would be staffing with us. So those were the types of things I started to notice right off the bat. The other thing I noticed was the metrics, what I refer to as malignant metrics. These are guidelines that were put out by the American College of Emergency Physicians and the American Academy of Emergency Physicians as to how patients and what time frame patients should be seen in. For example, if your patient checks into the waiting room, typically depending on their complaint, you had a set amount of time before that they were triaged and seen. In this facility, every patient, no matter what their triage level was to be seen within 10 minutes. Not only that, you would have to put in orders within 15 minutes. And beyond that, you would have to come up with a disposition for the patient in about an hour to 20 minutes, an hour and 20 minutes. And then if you were going to discharge the patient, it had better be in an hour and 45 minutes or under. And these were not just loose guidelines. You had to meet these metrics. You had to go by their standards.
And I'm gathering they were entirely arbitrary, and they gave no consideration at all to the complexity of the workup or anything of that nature.
Entirely. Absolutely correct. Emergency medicine and medicine in general, it's not a factory. You can't dictate who's going to walk through your emergency room doors at any given time. And you can't dictate what their complaint will be or how complex that patient will be. And there are things that are outside of the realm of your control that are factors, rate limiting steps, how fast the CT scan is read by the radiologist, or the chest x-ray is taken by the technician. How many patients show up after that patient showed up, and what kind of complaints do they have, and what kind of remedies do they require, and treatments they require. It is absolutely chaos with some element of order to it. As anybody knows in an emergency department, you can't control your day, but yet the corporation and the corporates above want you to try to lasso that experience as much as they can into these finite and arbitrary timings, which really disadvantage not only yourself, but disadvantage your patients. That's the most important thing. They're setting you up for failure, but they're also setting those patients up for failure.
That's very well put. So what's your plan to get us out of this mess?
Well, I started to dig a little deeper and understand why I was being made to see patients within 10 minutes. For example, one night in particular, I had a very bad night. I was treating a patient, and it's just as clear as day in my head. I was treating a patient who was a bicyclist who had been hit by a car and had some severe lacerations to his face. I called the plastic surgeon who happened to be on call, and the guy refused to come in. So I had to sew this gentleman's face up as best as I could and have him follow up with the plastic surgeon the next day. And in this, he had other traumatic injuries that were being worked up at the time. Then I had a postpartum patient that was bleeding. I had a septic patient that I was taking care of and getting medications and drips hung on. And I also had a chest pain patient check in at the same time who most likely did end up having an MI. I have all these balls juggling in the air, as most ER physicians do at any given point in their shift. And for the most part, they're able to delineate tasks and to understand the triage levels and the severity of each of these patients and really work with the ones that are needing their attention the most and then work their way down. In this particular night, I was told that there were 3 or 4 more patients that had checked into the waiting room. So I asked the nurse, who was the charge nurse that night, I said, what are the complaints? And she rattled off, well, there's some person who rolled their ankle and somebody who's, got a stubbed toe and somebody else who's got a headache. It's had a headache for like a month. And I said, well, none of those complaints seem particularly, high acuity or that need to be immediately seen. I have some very sick patients that are going to be needing my attention. So let's let them wait a little while in the emergency room. I'll get to them when I do. And she said, no, that's not the way it works, Dr. Rizvi. You have to see them within 25 minutes. And if you let them sit for even 30 minutes, it's going to generate an automatic email to the CEO of the hospital. And I said, excuse me? And she goes, yes, because the ticker on the I-70 highway out there is going to read that the wait times are greater than 30 minutes. And the CEO won't like that. And so you'll be called in for that. And I said, well, so be it, because it's my medical license, and the people that are needing my attention right now are needing my attention. And unless those people in the waiting room are deathly ill and need to come back right away, I'm going to give my full attention to the patients that need them right now, that need it right now. So the next day, I was called in by my director and told that I can no longer do that. Can't
By your
ever.
physician director?
My physician director. That
Wow.
the CEO did get an email, indeed, and the sister system generated the email automatically that the patient had sat there for about 25 to 30 minutes, and that I would need to speak with them and explain as to why I let that happen. They don't like to take any excuses. You have to understand, you're talking to people who either are physician administrators who have bought into the philosophy of the corporate non-physician administrators, or you're talking to administrators who don't have any clinical background to understand that you can't take your eyes off of the postpartum bleeding patient or the septic patient or the MI that just rolled in, and that an ankle injury can, wait. That's why we have a ESI triage level system. ESI level 1 and level 2 complaints get seen immediately because they are the highest acuity and they're the most dangerous, and they have immediate life or limb threatening emergency going on. And the level 3, 4s, and 5s are a little bit less, and there's a little bit more leeway of time. That's why we have that system. But to a corporate entity, each and every patient is not seen as an individual patient, it's seen as a dollar sign. And they don't want those dollar signs to walk out the emergency room waiting area.
So you were being evaluated not because of your clinical expertise. You were being evaluated on the basis of the scores that the hospital wanted to generate so they could say we're number one
Yeah.
based on nothing but a clock.
Mm-hmm. Absolutely. The scores and also the economics of it, right? So to them, they see it as purely a business. The more customers they can get through the door, the better it is for business. The more people they can herd in and herd out, clock in and clock out, the extraction of the dollars that they can get from those patients. Now, if a patient sits there a little too long and decides they want to go to a different emergency room, or doesn't feel that their emergency is that big of an emergency at the end of the day and leaves the waiting room, then that's dollars and cents left on the table for them. And so the patient that's dying in the room be damned, you're not going to let any of those people in the waiting room walk out.
How should we address this issue?
So the biggest thing I see that's going wrong in healthcare right now is the incorporation of these middlemen, these rent seekers, if you will, the people who are basically coming in between the physician and patient relationship. I've had the experience of working for a nonprofit hospital and a for-profit hospital, and I can tell you there's a huge difference in how they treat house staff and what goes on. The other interjection of what I found out in my particular field is that of private equity firms. So the corporation that I was working for, what's called Team Health, had sold to a private equity firm, Blackstone Group, a Wall Street private equity firm, in 2016 for, and the numbers are, forgive me, all over the place, but the deal was for close to $11 billion, $11 billion. With these private equity firms, their whole goal is to extract basically a return on investment for their investors. And they are looking for upwards of 20% or so on the companies that they take over or buy out. The questions we need to ask as a profession are, should we let companies that are solely looking to extract an investment out of healthcare and have nothing other to bring to the table of value to our industry, to our profession, really take advantage of it? Should we care about shareholder profits in the healthcare industry? The saying is you can't serve two masters. You can't serve both your patients and shareholders. We really need to start reevaluating the ideas behind for-profit healthcare conglomerates and that have really just taken this approach that healthcare is much more a business now than it has ever been. And also these completely, these investment firms who are just trying to extract value out of the healthcare experience.
Yeah, I don't think anybody would disagree with that assessment at all. And to your point, it appears to me, as a retired physician, that this kind of behavior not only exists among hospital corporations, but throughout the entirety of the medical care infrastructure, particularly pharmaceutical and medical devices and things of that nature. The profit motive has really gotten to be rather severe, and it is my impression that most doctors in practice nowadays see it as well. But I'm wondering if you foresee a solution.
A lot of these ideas go back in time to simpler time where, we really hone in and honor and respect the sanctity of medical practice and the sanctity of the doctor-patient relationship. Absolutely, we should not allow investment firms to buy physician practices. There is an element of choice on the part of physicians to sell to these investment firms. And we really have to go back to the ethics of our profession and to really start to teach the oath of our profession back to the medical students. The owners of these large groups that were physician owned at one point who decided to sell to non-physicians, there really needs to be scrutinized. And the profession has to go back to self-policing. It doesn't help that we no longer have a national organization like the AMA that no longer, the AMA no longer speaks for most bedside physicians. And so we really need to go back to having one national voice, I think. And there are groups out there, like I mentioned, like Free to Care and others who are doing this, but this has got to be a national movement. There are a lot of activist physicians now on all the various major social media sites who are exposing these kind of conflicts of interest and this kind of racketeering, if you will, and raping.
It's a good name for it.
Yeah, of our profession, and really that don't have the interest of the patient nor the doctors at heart. I always say this, that private equity is antithetical to the practice of medicine. Our goals are first and foremost to the health and well-being of our patients. They are not to drive a profit for shareholders. And we need to get away from that. Why are we selling to these companies? Why are we enriching the folks over in Wall Street? For what cause? And then also, they're ruining our way of practice. They're taking our autonomy away from us. That night that I was practicing, I was being told what to do by somebody who's never stepped foot and taken care of patients in the emergency room.
Right.
And that's got to stop.
My favorite expression as I left my beloved profession was the instant a physician goes to work for anybody other than the patient's going to be in big trouble. And I'm afraid that's where we are, and it sounds like you agree with me on that. I want to give you an opportunity to, before we close things out here, to give some recommendations to people about how they can help turn this thing around. Are there organizations, or there causes, or there groups that you would like to publicize where physicians can get their voice back?
Absolutely. There's so much more I could have talked about with this.
Well, maybe we'll do a two-parter.
With this podcast, because there's a whole realm of this that the corporations not only have taken over, but they've also started to basically breed our young in captivity, which means they've taken over residency programs and opened up residency programs, especially in the fields of emergency medicine. So they're teaching these residents how, I would say, the wrong way to practice medicine in a very fiscally oriented environment, and paying them less and less to think that this is how physicians should be compensated and were compensated, which could be further from the truth.
It's frightening.
It is frightening. The organizations, there's several. I mean, Free to Care is one of them. Practicing Physicians of America is another one. And Take EM Back is a new organization that I helped found with some of my ER members. American Academy of Emergency Medicine has been fighting corporate practice of medicine for 30 some years. Dr. Bob McNamara is one of the founding members who I'm very close to. The biggest thing I would tell physicians who are coming into medicine, and really I want to really, focus on also the academics in the nation. It is your responsibility if you're an academic physician to not ignore these factors, because you think that this is not going to happen to you. You're sitting in the ivory tower of academic medicine. But the corporate takeover of medicine is well underway, and it's been underway, and it's going to come for the academics, and it has in a lot of ways. I would say if you are able, and if you are going to choose a specialty where you can independently practice, by all means do so. Whether that be family practice, cardiology, urology, what have you, open up your own shop and be your own boss and stay independent. Do not go into an employment situation with any of these hospitals or large conglomerate corporate owned groups. Yes, if there's a small physician or mid-sized physician or even a large physician owned group, sure, but do your due diligence and try to stay as independent as possible, because that's serving yourself and serving your patients in the best way possible.
Well, you know what? We could, obviously, you have well pointed out that we could go on with this conversation for a long time. And I tell you, you have really articulated this better than a lot of people that I have read and talked to. And I think we might actually think about doing a part 2 or a part 3 or who knows, maybe more, to talk in detail about this very subject. But I've kept you here for a very long time. I know you have other things to do. So right now, I want to thank you for everything that you've offered today. And then I'm just going to step out of the way and we'll get to the heart of the program. And for our audience, I'm going to sit quietly while Dr. Saba Rizvi gives us her prescriptions for success.
Oh, thank you. I'd love to be invited back, and this has been a fantastic conversation. Very, very easygoing. My prescriptions for success. I've already mentioned one of them, but always try to obviously do what you're passionate about, and you're never too old to pursue your passions. I'm pursuing JD now. I'm kind of mid-career, so never too old to gain more knowledge and an education. If you see a problem in life and are experiencing something that just doesn't make sense, try to find out more and try to get to the bottom of it. Be your own investigative journalist, if you will. You'll be surprised what talking to others and who are having experiences similar to yours, and or whether that be in your professional life or personal life, you can gain so many insights from just really delving deep and trying to do some of your own research. And number 3, I would say, there's nothing like having autonomy, freedom, and liberty. Always try to be your own boss. Don't give up on trying to stay independent as a physician. That's the best way to serve your patients. And I think that's pretty much it for life lessons for today.
Well, thank you very much. It has been a pleasure speaking with you today. I've learned a lot, and you have given me reason to be hopeful that maybe we might turn this thing around. Before we go, I want to give you an opportunity to let our audience know where they can find you. So if you have Twitter handles or email addresses or websites or groups that you want to publicize or books that you've written, please go ahead and tell us.
Sure. So I am on Twitter. My Twitter handle is Saba Rizvi MD, and it's SABARIZ as in zebra, V as in victory, IMD. And I am a member of the American Academy of Emergency Physicians, as well as Take EM Back. So those are 2 groups on Facebook and Twitter that you can find, and also a part of Free to Care.
Well, Well, Dr. Saba Rizvi, once again, thank you very much for being with us. It's been a pleasure, and I hope you have a good day.
Thank you. Thank you so much for having me on.
Thank you so much for listening today, and thanks also to Ryan Jones, who created and performs our theme music. Remember, no matter where you listen to us, we'd really appreciate a review and hopefully a 5-star rating. Your feedback really does help us get better. Also, please visit our website at rxforsuccesspodcast.com, where you can offer your very own personal prescription for success on SpeakPipe. You might just hear it played back on one of our shows. And of course, be sure to fill your prescription for success with my next episode.